My name is Per Aspenberg. I am an orthopedic surgeon. It's me you see in the middle of this image with my hands on my back, but that was 40 years ago. I would like to talk a little about hip and knee prostheses, total joint replacements, and why some of them, a few, tend to come loose over time. This will lead to a discussion about research that could be of great benefit to patients, but that is never performed, and why that is. Millions of people are living their lives with total joint replacements that function perfectly and that will never come loose. However, a small minority of these implants will develop prosthetic loosening, meaning that they are no longer anchored to the bone. Over time, this can become painful, and the patient would need some kind of new surgery where the old prosthesis is taken out and a new one inserted. This is a much more demanding procedure both for the patient and for the surgeon, and it may happen that since years have passed, the patient has now become too old and frail to withstand such surgery. This presentation is about a simple, cheap and safe method that might prevent prosthetic loosening. This is a hip prosthesis, and here is another one, and this one has become loose, as you can see. It is no longer fastened to the bone, and that is because a specialized kind of cell, bone eaters, osteoclasts, have eaten up the bone that the prosthesis was anchored to. But we will have to take this from the beginning. This is a bone, and here is an osteoclast, a bone eater that wants to eat it. Now it has started eating. This is no good. Too little bone in the body will lead to problems. There is a group of drugs called bisphosphonates. The most common one is a tablet named Fosamax. When a bisphosphonate enters your body, it will immediately bind to all bone surfaces, and any bisphosphonate that is not bound to bone surfaces is eliminated from the body within a few hours. Here is the osteoclast again, and now when it eats the bone, it will ingest the bisphosphonate, and that will inactivate the cell. In this way, bisphosphonates reduce bone loss, and they are very good drugs against osteoporosis. 20 years ago, when bisphosphonates were new, I came to think about the possibility that they could be used in the context of prosthetic loosening, or rather in the context of initial prosthesis fixation. But we'll have to take some basics again. This is a bone. Now we put an implant to the bone, a total joint replacement. And when you do that, there is always a small gap between the bone and the implant in the beginning. In this gap, osteoclasts will turn up and start eating bone. Luckily, the bone tissue will experience the surgical trauma as a fracture and send cells there to try healing it. Bone builders, osteoblasts, and they will compete with the osteoclasts, and usually in the long run, or rather short run, they will win, so that the prosthesis finally becomes anchored to the bone. Sometimes, however, the bone building response is not strong enough, and the osteoclast will win the battle. That means that the implant will not be fastened to the bone, but to fibrous tissue at the interface, a scar. Usually that's not a problem. The patient won't feel the difference, and the prosthesis might function for a lifetime anyways. But it means that there is a risk for late loosening to develop, and I will come back to that later. So we thought that if we could inhibit the bone-eating cells at the time of operation, we would have a higher probability of solid bony fixation. In order to test this idea, we need a method to measure how well a prosthesis is fixed to bone, and there is such a method. It's called radiostereometry. What you do is to insert little metal beads less than 1 millimeter diameter. These beads are visible on radiographs, and when you do a three-dimensional X-ray, they will form a body in the bone that you can use to define a coordinate system that will be constant over time as the beads are fixed. Now you can define the position of your prosthesis in relation to this coordinate system, and you can see changes over time with a very high precision, just a few tenths of a millimeter. We started our research in the 1990s on a total knee replacement. So here you see a knee from the side with a joint surface that has been replaced. This replacement can move in relation to the bone and usually tilt backwards a little, as you can see here. We started measuring this with radiostereometry, and here you can see our first results. The graph shows how much the prosthesis has tilted backwards at 6 weeks, 6 months, up to 4 years. And as you can see, the majority of patients at 4 years have tilted a bit backwards. It's not much, it's only a fraction of a degree, but it indicates that the prostheses are not well fixed. It could be better. These patients are not just any patients. They are the randomized control group of a trial where half of the patients received bisphosphonates. And here you can see how the bisphosphonate prostheses behaved. They didn't move. They were better fixed to the bone. We were very happy about these results and published them in an article already in year 2000. And this article was awarded, and I traveled to some congresses and presented the results, and people listened, not very interestedly. And then it was quiet. Nothing more happened. No one was actually interested. And we thought, no, that's not so unexpected, because orthopedic surgeons want to do things with their hands in the wound in the operation room and not prescribe tablets. So we repeated the study in exactly the same way, except that at this time we did the treatment in the operation room by sprinkling a bisphosphonate solution onto the bone surface before the prosthesis was inserted. And the results were exactly the same. The prosthesis became better fixed. We wrote a new article, went to new congresses to talk about this, and again people listened politely but not very interestedly. And then nothing happened at all, and no patient ever got this treatment. We later did the same thing with total hip replacements, and here you can see the results from the placebo group, where each dot represents one individual, and you can see that the prosthesis has moved a little in relation to the bone. Now, again, by random, half of the patients received a bisphosphonate locally applied to the bone surface before the prosthesis was inserted. And here you see their results. Actually, there is an error of measurement, so the data within the box on this image might actually represent prostheses that have not moved at all, but those outside of the box have definitely moved. And as you can see, much fewer of the patients that received the bisphosphonate did move. So we thought we can use bisphosphonate as a tool in the orthopedic toolbox. But no one was interested. Why? Well, it's actually quite understandable. We had shown with quite good evidence that bisphosphonates improve fixation. And one would think that better fixation reduces the risk of loosening, but in those days when we started this research, many people believed that initial fixation wasn't that important because late loosening had other reasons. Now we know for sure that better fixation reduces the risk of late loosening. So if bisphosphonates improve fixation and better fixation reduces the risk of loosening, bisphosphonates should reduce the risk of loosening. Well, no, it's not that simple, because even though we know that better fixation reduces the risk of loosening, we don't know if better fixation due to bisphosphonates reduce the risk of loosening. We have to show that. And that is too expensive. We would need to randomize thousands of patients and follow them for many years, and no academic institution, at least in Sweden, can afford that. So here is the problem. We have a treatment that we believe is of great benefit to patients, but the medical profession is not entirely convinced and requires better evidence, and we cannot afford that. So we would go to industry that produces the drug and ask them to support a big trial to show the benefit of bisphosphonates. But they would answer that there is no money in such research because they can sell only one single dose per patient to prevent loosening, whereas they can sell repeated doses over many years to treat osteoporosis. And by the way, they would add, the patent is soon out, so there is no money in it at all for anyone any longer. So there we were. Our research came to a standstill, and nothing happened for almost a decade. Luckily, the Swedish government made a call the other year for clinical studies that industry would never be interested in funding. And now actually we have started a trial including 1,000 patients that will be randomized to zoledronate, bisphosphonate or placebo, and followed for 3 and 5 years with a questionnaire. We believe, namely, that even though it might take many, many years for loosening to develop to such a degree that the patient comes to the doctor and asks for something to be done, it actually produces symptoms at a much earlier time point. And that's what we will try to prevent. So in a few years we will have the definite evidence if this cheap and simple treatment actually works. The study is a randomized trial, meaning that treatment is given to half of the patients by random. The great thing about such a study design is that the difference we see between the two groups can only have two explanations. Either it is the treatment or it is random. And the probability that random explains the difference is easy to calculate with statistical methods. You may think that perhaps by chance there are more smokers in one group than in the other, and that could explain the difference. But that's not a problem, because if there are more smokers in one of the groups, that's because of random. And we have already calculated the probability that random explains the difference and found that it is low. There are many randomized trials that should be done. For example, this patient with a fracture. Is it better to operate or is it better to treat it with a plaster only? Only randomized trials can answer that kind of questions. The problem with randomized trials is that they are complicated to organize and rather expensive. In order to answer these simple, straightforward and clinically important questions, we need that society in some form organizes and funds randomized trials. We shouldn't depend on industry to decide which research questions are the important ones to answer. I am very happy to have received funding to show whether bisphosphonates actually do reduce the risk of late loosening, as we believe, and in a few years we will have the answer to that question. Thank you very much.